Hey, everybody, welcome back to the Overrun podcast. My name is Ed Bowder.
And I'm Dan.
And this is EMS Week. And with us is Dr. Zaf Qasim from Philadelphia. He is an EMS, EM, critical care, pre-hospital, jack of all trades in the great city of Philadelphia. Dr. Qasim, thank you for joining us today.
Hey, thanks for having me. Great to be back on the podcast.
Yeah, excited to talk to you. So we want to talk about different advances in resuscitation for this EMS week, and certainly there's a lot to talk about. Over the past 5 or 6 years, we've had many different advancements in the practice and in the trade. So what we're going to do in this episode is we're going to take a little bit of time and talk about medical resuscitation, and then after the break, we're going to talk about trauma resuscitation. So Dr. Qasim, in your estimation, talk to us about some of the advances in medical resuscitation. And I guess let's start with the biggest ones, some of the most important ones, some of the changes that we've seen in CPR and cardiac arrest and where we're going, what direction we're moving in that section for the patient population.
Yeah, it's a really important topic. As you know, we still have overall, unfortunately, poor outcomes from out of hospital cardiac arrest. And I think the biggest theme over the last decade has been, going back to basics is the really important thing. And so we've seen a lot of change from like a focus on ALS interventions to more BLS interventions, a real focus on compression only CPR, getting bystanders involved early, defibrillation. And so probably one of the things that keeps rearing its head that I thought was probably interesting to talk about is this heads up CPR. And that's kind of been back and forth in different kind of forums of discussion as well as conferences. And I wanted to expand on that a little bit. So head up CPR, you may have heard about, it's basically kind of trying to get the head of the patient up, elevated a little bit, usually about 30 degrees or so, to improve outcomes from out of hospital cardiac arrest resuscitation. And the premise is based in physiology. So if you think about how the main effects are of cardiac arrest resuscitation, it's to restore kind of perfusion to the heart and the brain, and primarily the brain, so that the brain being deprived of oxygen, you want to try and get that restored as quickly as possible and as well as possible, so that your overall important outcome, which is neurologically intact survival, increases. And so there was a lot of interest in this heads up CPR based on animal models. So a lot of pig studies showed that by elevating the head, it seemed to improve perfusion to the brain. And the reason was that by laying the head flat, there seems to be no real kind of differential in blood flow when you compare it to the pressure within a closed box, which is the skull. So the theory was that if you raise the bed, you increase the venous drainage, and that decreases the pressure within the brain and hence allows increased flow into the cerebral perfusion. And really, if you were a pig, it's great because the animal studies were fantastic and we saw great survival amongst pigs and they're all happy out there now. So, but of course, the question is what happens in humans, right? And I think
a whole bunch of pigs on a farm with a CPC-1 walking around.
Yeah, exactly. Right. So they're really happy.
We did it. We saved breakfast, Zach. We did it. Everything's fine.
Like one pig's going to the other. You're not going to believe what happened.
It gives new meaning to saving the bacon, right? So of course, you want to translate data to the human world. And I think this is, to be honest, where we kind of got ahead of ourselves a little bit, because there were a couple of papers that came out in human studies that by a few select authors, I'd say, that really promoted this method and seemed to show, at least when you read the abstract of those papers, that head-up CPR was now, or should be, the standard of care. In fact, I think a group of EMS chiefs actually put out a statement a few years ago saying that, this has to be the standard of care, and that met with a lot of flack, because really when you look at the papers, unfortunately, the methodology of those wasn't great. They seemed to show that the head-up CPR patients did better. But a lot of these papers were like crossover studies. The populations that they were comparing were not really equal. They kind of did a thing called data dredging. So they tried to find results that kind of matched their hypothesis. And unfortunately, it didn't really bear up to scrutiny. Um, I think the biggest thing to take away really is that they looked at a bundle of care approach, and that included having pit crew CPR, early compressions and effective compressions, and kind of avoiding advanced airway maneuvers, just focusing on basic airway techniques like placing an LMA or iGel, and using that, and then adding the head-up CPR component to it. So it's really difficult to tease out, is it just that we're better at doing the basics well, or is it adding this new technique that's improving the outcome? So certainly, I think something to keep an eye on, but I wouldn't say that it's really the standard of care right now that we should be implementing this head-up CPR for human resuscitation.
So you're not going out and buying your those heads up gadgets that you're seeing that are in the market already that were advertised in the magazines.
I think only if I want to like relax by the pool, I can use those to kind of prop myself up. But I'm not going to be throwing it in the back of the rig for now.
Fair enough.
Well, but it's another example of, there's a little bit of data that supports something, and now we have this big sexy toy that we can play with, and that's really exciting. And it's almost like the conflation of, modern practice with just new stuff. Right. And, the same thing. And so we'll dovetail off of the heads up stuff, because I want to apply it to, band and piston driven devices too, because I worry that we're getting to a point, and like, don't get me wrong, I like sexy new toys too. I have an iPhone. I have, we have these, I'm wearing Apple, AirPods Max. Like, I like new sexy toys, but I like new sexy toys that work. And I worry that we focus too much sometimes on the equipment and not so much on, the outcomes. So if you're an organization that has all this extra money, there are people who are buying the commercial heads up beds. There are people who are buying, band driven devices, piston driven devices. And I wonder what your thoughts on those are. Are we improving outcomes? Are these, for lack of a better term, toys making things better? Or are they just kind of things that make us feel better? Or, what kind of, I guess, utilization can we have with these toys that we have that so far haven't really shown scientific outcomes that we want?
Yeah, I think it's a great point because, certainly from a market perspective, there's a lot of people jumping on bandwagons based on variable quality literature. And so I think, the head-up CPR equipment is kind of the same. And I'll go back and say that, the real effectiveness of that is in combination with something like an impedance threshold device as well as a mechanical CPR device. And so you have to have a few toys in order for that to actually show potential benefit. But I think, there is some value in some of these pieces of equipment, even though the literature doesn't bear out. So, for example, the mechanical CPR devices, the Lucas and others, similar kind of mechanistic approach. Overall, the papers have been variable on that, whether it's beneficial or not. There is a risk to it, especially if it's misplaced. You can cause damage to abdominal organs. And, if you know it placed it right, you might actually block outflow from the heart. But I would say, and any medic who's tried to do quality CPR in the back of a moving rig will know this, that, doing that is impossible, right? Not only is it not effective, but it's unsafe for the paramedic, right? Or the BLS medic as well. It's, you're driving fast, you're at risk of injury to yourself, and you're not doing your patient any good. So I think from a logistical point of view, some of these pieces of equipment that are coming out can be really useful, even though they haven't shown maybe the best change in outcomes. And that's, I think, where people should really be thinking about it. Logistically in my system, will this kind of help us do what we need to do, which is the basics well? And if that's the case, then sure, spend your money on that, but don't think of it as like a panacea that, if I use this, then my patients are going to do better, until we get better evidence for it.
And we talked a little bit the other day about eCPR because that's starting to come out now too. There's a couple decent cases we talked about at Journal Club coming out of Japan. So failing all of this other stuff, right? The band-driven device isn't working, the piston-driven device isn't working. Heads up isn't working. Where it looks like as an industry we're slowly moving toward at least VV ECMO out in the field. And this might be a 10 or 15 year thing, but we're kind of moving there. Talk to us a little bit about eCPR. What do you think about it? And what I want to get to is big picture, in a year or two, right? I want to know, to your mind, what does cardiac arrest look like, right, in this evolution of the practice?
Yeah, sure. I think eCPR is a real kind of game changer in our, the refractory VF patient. And we've all seen those patients, right? We're working hard. They're just not getting out. We try maybe even double sequence defibrillation, and they're still not able to get out of that rhythm. And I think, there's ample literature now from the Europeans, from the folk up in Minneapolis, that eCPR and the right group of people is really effective and really is a tool that we should be using. But the reality, of course, is, you're, for example, in Philly, you're not going to be trying to drive that huge truck around the streets of central Philly, nor is it
There's
something
plenty
that
of room down in South Philly. Are you kidding me?
Right? You can just get
I'll take that.
stuck
I'll
on
take that
one
ECMO
street.
truck down Reed Street all day, all day.
Right? But yeah, so the reality is, not many systems in the U.S. have physicians that can go out. Not many systems have funding to be able to do that. So what do we do? But I think there is value to looking at how we identify patients that would benefit from eCPR and getting those to cardiac arrest centers, just like we have protocols for getting people to trauma centers and stroke centers and things like that. So being able to bring the patient to somebody who can provide that care might be the way to go. And I think, the challenge there is, in the last decade, we pushed so hard for people to continue working on scene until you get ROSC. And now you're telling people to, no, for a group of people, you get up and go and leave the scene quickly and continue your care en route.
Stay on scene the whole time until you don't stay on scene the whole time, right? Yeah.
Right, exactly. I think that's the challenge, right? To change that kind of culture. But I think that's a feasible way to go in US EMS and probably in many other countries as well, is that medics need to be thinking about, is this patient amenable to an intervention like eCPR? And if so, then those are the patients that we need to just load and go rather than stay on scene and continue like a pit crew CPR approach. So that's where I think we can feasibly implement CPR continuum from the pre-hospital to the in-hospital setting.
Do you think it's a possibility where the numbers for survival aren't good because we haven't had the right system in place yet? Maybe in the future when we have cardiac arrest centers where we can identify viable patients in the field, do the interventions that absolutely have to be done there, get them to a place where they can go on pump and then go up to the cath lab and have their catheterization, get that lesion removed. Maybe that's where the survival benefits are going to start being visualized.
Yeah, I think so. And actually, Minneapolis kind of looked at that model care delivery when they first set up, because what they had was they talked to a bunch of 3 or 4 different hospitals and a bunch of EMS agencies and said, hey, everybody should be on the same page about identifying these folk and then bringing them rapidly to a hospital that we can, 24/7 be available to put these people on to ECMO. And certainly, so, it needs buy-in from the health systems that are being involved with it, and it needs buy-in from EMS agencies and EMS leadership to be that. And it's really just a reflection of what we've already done for other pathology. Stroke probably being the most recent one, where over the last 15 years or so, we've really kind of changed the emphasis on being able to provide early stroke intervention. And so we can do the same model for cardiac arrest. And I agree. I think that system change is really where the mortality benefit is going to be.
And certainly there's other places that are doing ECMO out in the field. We talked about Minnesota. They have a enormous vehicle That's very, very well spec'd out. And Danny, you're more well traveled than I am. You've seen the SAMU unit out in
Oh
France,
yeah.
and seeing, and again, obviously, if you've seen a system, you've seen one system, but seeing the SAMU unit in Paris operate, where they've essentially set up a field operating room, on the shores of the Seine. So when you've seen that type of operation, it's kind of encouraging to see, like, all right, well, if they can do it in this type of setting, we just have to get the right kind of champions to do it in our kind of setting. So
Yeah.
if we have places where, and I'm just using SAMU as an example, where they've got, this system has their buy-in, they have the people, they have the equipment. What can we kind of learn from those organizations and help move to our organizations, and I guess kind of help progress this industry, this profession, this this industry that we're in? Because I get frustrated seeing, like, oh, we should be doing ECMO, we should be doing all this stuff, and agreeing, and then it's like, well, they're just going to do it in other places. So if we're trying to advance these things, I guess, and I want to hear both of your opinions on this. What is our path forward on trying to sell our teams on these enormous ambulances?
So I think, and I've been lucky to similarly go out to Paris and London and see kind of their advanced systems and stuff.
Both of you can flex your Parisian travel. That's fine.
But when you boil down, why their systems are successful, it's not because they can provide all these things. They could be the most expert technicians in these techniques as possible in the world, but if they don't identify the patient that will benefit, there's no point. So if they're not there, then there's no point. So the real common denominator in these systems that works is good dispatch. And that, I think, is where we really struggle, partly because of how EMS is set up in the US, with so many different EMS agencies that might be feeding into different dispatch centers. Partly maybe because 911 calls go to police first and then get moved on to an EMS dispatcher, or whatever the reason is. But the key thing is, we need to look at being able to get the resource or identify the patient that would benefit much faster than we are already. And that's where we can already use technology that's out there. So there's like video calling technology. You can use these apps like they have the Good Sam app, for example, that actually allows video to be sent from the scene to the dispatcher. And so they can send a link to the 911, whoever called 911 to their phone. They can start a video and look at the patient. And if somebody can then look at the patient and say, hey, yeah, they look like they meet this criteria, let's mobilize these resources first, that could be the way to achieve what I like to call marginal gains, which means that you shave off a few minutes here and there to be able to get them the care that they need. So I think people don't focus enough on dispatch here and the benefits of good decision making for dispatch, and that's where perhaps the real benefits might lie in our system.
I agree 100% with you, Doc. I think dispatch and patient selection is extremely important in this role. CPR does not save the dying person, does not save a dying heart. CPR is a placeholder for that person who has suffered an insult that is survivable. I think in this country, the paradigm has to change from looking at everybody gets CPR all the time for whatever reason, and we resuscitate everyone no matter what, to, is this person going to benefit from it? Is this a tool we can use, or is this a non-survivable event? I know when I'm 95, hopefully, that I don't want CPR. I don't want to be resuscitated. It's a brutal process. It doesn't show good outcomes, especially for the elderly. It's dismal, and we're just doing things for the sake of doing them. But patient selection is huge.
No, and absolutely. And I think we all kind of have that moment where, like, I don't want CPR done on me at 95, and I just barely want CPR done on me at 39. It's not. It's, I appreciate the effort and the thought, but I think that patient selection is a very important part. And Zaf, I'm really glad that you made that point, where I think that we tend to operate under this assumption that we have to do everything for everybody, and whether that's an ego thing, whether that's a legality thing, I'm worried about being sued or whatever else. But on the obverse, you have people who don't do CPR because they're afraid that they're going to hurt the person. So it's a systemic thing. It's sort of like this insidious thing about how we treat cardiac arrests and how we actually get out to them. We have a whole bunch coming up after the break. We're going to talk about trauma, ultrasound, resuscitation, more stuff for EMS week from Dr. Zaf Qasim. Stick around. We'll be right back after the break. This episode of the Overrun podcast is brought to you by Team Life. Your hands can save a life. Learning how to perform high-quality CPR can be the difference for someone experiencing cardiac arrest. Team Life offers CPR certification classes throughout New Jersey taught by trained professionals. Sign up today for CPR certification classes at teamlife.com and learn the skills necessary to save a life. Anyone can be a hero. Now back to the show. All right, gang, welcome back to the Overrun with Dr. Zaf Qasim. The A block, we talked about a lot of CPR stuff and more medical resuscitation. There's a lot of really interesting devices that can be used, and we talked about all those sexy toys. But now let's get into the stuff that people want to go into EMS for. Let's talk about trauma and all of the big trauma resuscitation updates that we can get to.
Let's get sexy.
Let's get sexy. So to start, Zaf, let's go into changes in trauma resuscitation, because for a long time, and I worry that this hasn't gotten out to everybody, we were still giving fluids and still doing all that. And now the data is moving toward just give whole blood. 3-4 years ago, we were arguing, do we need, we need pack cells or plasma? What do we need component therapy? It's all kind of starting to lean back toward whole blood. So I want to get your thoughts on that. And then let's get into some of the more fancy stuff we can do for trauma.
Yeah, totally. So I'm a big proponent of whole blood. We've been using it at our center for over 5-6 years now. And really the data that came out with the recent conflicts overseas pointed to really moving the needle on trauma mortality. And it makes sense, right? If you're losing whole blood, you should get whole blood back. And so and I think slowly the civilian trauma community and pre-hospital community has really picked up on that. You see more in the hospital, and now you've seen more and more agencies pre-hospital that are carrying blood and are able to administer this. There's a lot of logistical hurdles that people need to look at to be able to bring this forward. I think the payoff is really great, because certainly the civilian literature is kind of catching up with the military literature that shows that these patients are just better resuscitated physiologically, and there's less coagulopathy later on down the line than even if you're using component therapies in the best balance that you can. So it just makes sense to incorporate that. Having said that, if you're not giving blood at all and you only have access to packed cells and plasma, by all means use that in your pre-hospital setting. So replacing blood with blood is really the way to go. The logistics are getting easier. I think people have been really willing to share how systems have set their own programs up, and I think that's been really exciting to see how collegial people are in that aspect. It requires negotiation with your blood delivery providers, whether that's the regional blood bank or the hospital. There's ways that you can circulate blood back and forth between the pre-hospital and the hospital setting to make sure that you're not wasting units. And even on a regional level, there's been ways that smaller community hospitals and larger trauma centers and pre-hospital agencies have kind of worked together to continue circulating a unit, which, depending on which preservative you have, can last from 21 to 35 days. So it gives you a long period of time that you can use it. But I think the biggest and most exciting thing that has come out of it is that it's now really changing this scoop and run mantra that we've been taught for 30 plus years that in reality hasn't really changed our trauma outcomes in years. The real importance is to shorten the time to meaningful intervention. If you're doing that in the pre-hospital setting, that's great. And a lot of people say, well, that's great if you're out in, say, some rural area. Is Jersey Shore rural? I don't know.
if only it was. No, it's Memorial Day weekend at the Jersey Shore. Our population has doubled in the past week.
There you go. But the urban environment can certainly benefit from this, and the folk down in New Orleans have really shown some benefit of this. So they implemented a blood program in there because they see a fair amount of penetrating trauma, as you can imagine, in New Orleans, and they have pretty short runs to their trauma center in general. But they decided to give blood to gunshot victims as well. And even though their scene time was maybe a little bit longer than it had been because of the logistics of giving the unit of blood, they found that they actually the time that the patient received that first unit when compared to giving nothing and waiting for the blood to be given at the hospital, even when you factored in that increased scene time, it was faster for the paramedics to give the blood than it was for them to just scoop and let the hospital take care of it. And these patients arrived in a better physiologic state. Less of them needed to be intubated for altered mental status. And overall, I think their trend to mortality, at least in the short term, has improved. And so you can see that this can benefit in all types of pre-hospital environments, whether it's places where you're more rural or have longer scene times and transport times, to even urban environments. So the benefit is really playing out in all these places.
Yeah, it's almost like we've gotten away from the scoop and run and the stay and play mentalities, the camping out on scene complaints. I've always kind of explained it to the students lately that it's an investment, right? Time is an investment. And just like everything, you want a return on your investment. If you're going to get something on the back end, it's worth doing at the scene. Like if you have to pack a wound to stop an arterial bleed, the benefit you're going to get from taking those couple minutes and doing that well is going to far outweigh the time you spend on scene, because that's going to be a viable patient at the trauma center that the surgeons can actually do something with. There's no sense in bringing somebody in, exsanguinated hemorrhage to a trauma center where now we've got to work behind the 8 ball. I mean, look, if you're sitting on your third attempt trying to put a 22 in somebody's hand, you're not going to get a return on investment there. But if that person needs an airway and needs it properly done and you have the ability to do it, you bring a more stable patient to that trauma center and they can benefit from that. We've all seen, the crash thoracotomy in the trauma bay. We've all seen the chaos and the confusion, even in the most well-mannered situations. And if you have the ability to mitigate that or stop that on the scene, we should be doing it, because we're going to get a benefit on the backside. If there's no benefit on the backside, it shouldn't be done in the field. Would you agree with that?
Totally. Yeah. So meaningful intervention is what I think is useful. So it doesn't make sense to put an IV in and give crystalloid. That's no benefit to the patient. But if you put an IV or an IO in and you're able to give blood while you're still transporting. In fact, we kind of changed this. We put out a paper a few years ago where we kind of took this term and turned it into scoop and control, meaning that you're still maintaining that momentum to definitive care, which means the hospital, but you're providing meaningful intervention in the time that you have with the patient. And so, do something that will improve the outcomes for your patient by all means, but still kind of keep that momentum that we need to get to the hospital.
I love it.
And staying on that tack, in trauma, we worry about, hypovolemic shock and hemorrhage and all that. We had Dr. Devin Dromgoole on last week to talk about ultrasound, and we did a brief review, parasternal long, parasternal short. Talk to me about how we're applying pressors and ultrasound into trauma resuscitation, because it's starting to sound like we can see these benefits in real time, right? If I'm giving a pressor, I'm giving blood, and I have a probe, I can actually see the left heart squeeze improve right in front of me, and it's starting to feel like playing off of the scoop and run type of thing. We're starting to do more pre-hospital medicine in the pre-hospital environment where it's supposed to happen. So if let's say we have everything at our disposal, we have ultrasound, we have pressors, we have whole blood. Talk to me about what that resuscitation looks like in your mind. And is this a practical way forward, or are we just getting too many extra things when maybe we should be focusing more on just doing CPR?
Yeah, that's a good point. So ultrasound's been in trauma for decades now. The classic is that we do this fast exam in the hospital to look to see where people might be bleeding from. But I think as we've evolved, the looking at the heart and how important, imagine how important the heart is in our resuscitation really makes sense. So you
Is it?
can
Is
use,
that a thing we need? Do we need the heart?
right? So you can use pre-hospital ultrasound. There's several papers and agencies that have effectively implemented it. And I think, especially in, say, a blunt trauma patient where you're not sure what's going on, it can be useful. If nothing else, I say to my medics and my residents, if you only need to get one shot or two shots, then look at the heart and look at the right upper quadrant, which is usually where the blood might pool. And so you can get a quick idea, is there something in the belly that's bleeding? The caveat there is if they have like a retroperitoneal bleed, that you won't see that on ultrasound typically. But looking at the heart, I think, is really great. You can see how hard it's working, whether there's a cardial effusion or tamponade kind of that's building up. And actually, you can watch it if you keep the probe on it and you're giving volume. You can see how the dynamics of the heart change. So you can see it starting to fill, and you can see that the squeeze is much more effective as blood volume gets into it. So I think when you're deciding, hey, I've got 2 units of blood, say in my rig, I'll give one. Should I give the other one? Putting a probe on the heart, looking to see what it's doing might be actually a useful thing, just to decide whether you're going to use that limited resource. So I think there's certainly benefit of doing that. And then for other pathologies, so for example, you see that this patient has pericardial effusion, but maybe they're not in tamponade and they're kind of crumping, and you go, oh, should I intubate this patient? And trying to intubate someone who's got a pericardial effusion that's evolving into a tamponade, you're guaranteed to kill them. And so, if you see that, maybe you'll just stick to your basic airway maneuvers and support them in the ride to the hospital. But immediately you have information to give to the trauma team. Hey, be careful. They've seen this big effusion around the heart. And so just factor that into your resuscitation strategy. So I think there's a lot of information that you can gain both for the resuscitation that you're doing, as well as immediate information that's actionable by the receiving team in the hospital.
Yeah, and just another thing I thought about with the tech. I mean, things are getting so great. I mean, look, we send each other TikTok videos all day, right? How great would it be to send this information directly to the trauma team? Like, hey, I just looked at their heart. Here's what's going on. And then it sets you, as a physician, it kind of sets you up for success, because you're like, oh, now I know what I have to do. And this is what the surgeon's going to have to do. And this is what we need when they get here. So let's start getting this together, and let's start getting, blood up from the blood bank. And, I just think it's got the potential to do really cool things out there and improve survival.
Yeah, totally. Why are we just relying on the radio just to transmit information when, you can send the picture to someone's phone, or, we already do this in some systems with EKGs where we send the EKG to the hospital
Yeah.
beforehand. So it's just a natural extension of what some systems are already doing. So I agree with you. That's a great use of technology.
I submit we can use TikTok to send things to receiving hospitals. I just want someone to be doing a dance in the background. That's all I want from it. Right? You pull up, like, oh, their shock index is 1.5, but there's someone doing a jig in the background. Like that's where I want medicine to go. Give me social media.
I want to go old school. I want to be doing like a humeral head IO while we're doing the Harlem Shake in the background. Go old school.
But again, there's applicability to a lot of these toys that we're using, and because we're talking about trauma resuscitation, I do want to take some time. I want to talk about use of airway medications, specifically ketamine and fentanyl, and then I also want to talk about the over or under use of flight paramedicine before we get out of here. And so again, we've got all these great tools. I agree that ultrasound works. I think that's going to be the next big thing. Years ago we had conversations where an ultrasound probe is going to be the new stethoscope. So I'm certain that that's going to happen eventually. So as long as we have these tools,
I would say that I've yet to see an ultrasound that can tell me that the patient is wheezing. So
all right.
Like zing.
There's somebody somewhere who's like, I'm going to make it. Now I got an idea. This is how I'm going to make my million. But because we can track these patients in real time and get real time feedback, when we have medications that we give like ketamine, where in an RSI scenario or in a trauma scenario, it can get very kind of energetic. You can give ketamine too fast. You can have patients lose their respiratory rate. Talk to me a little bit about, I guess, your feelings about ketamine and fentanyl in RSI and in the field. Because I'm not convinced that there's a debate that says we should get rid of ketamine and fentanyl, but I think people are still kind of arguing against it. And I'm just wondering what your thoughts are with that type of RSI setting in trauma.
Yeah, sure. It's so just to focus on the trauma airway. So I think many people have kind of adopted now this either March or CABC approach to trauma airway management. And we've seen certainly in the hospital, our practice has changed over the last 6-7 years to, adopt the mantra of resuscitate before you intubate. So stopping bleeding and starting to transfuse before you manage the airway can be really beneficial. In fact, some of these patients, once you give them blood, what you thought was altered mental status suddenly improves because now they're perfusing their brain and they're waking up and they never needed to get intubated anyway. So that's the first thing is always remember that controlling bleeding and restoring volume can go a long way, and you can use basic airway maneuvers in the meanwhile just to support the airway. But if you do have to intubate, I think ketamine's still a great drug to use, and there's a lot of controversy. I don't have to tell you guys about it, about the use of ketamine in the pre-hospital setting, based on several, famous cases and court verdicts. But in the right hands and with the right protocols, it's still a great drug. It's got a pretty good safety profile, and we use it for our RSIs now in the trauma bay. I think the key thing is, when you're thinking about intubating someone who's in shock, is even not so much as the drug itself that you're using, but more so the dosage that you're using. So once you've resuscitated the patient, you've gotten some volume in, and you're proceeding to the RSI. If they're still kind of shocky, so their shock index is like 0.9 or 1 or more, then think about going half dose or even lower with your ketamine dosage for the intubation. So, most places will probably use 1 to 1.5 mg per kg for their ketamine for RSI dosing. You might drop down to even like 0.5 mg per kg just to minimize the effect of any kind of cardiovascular instability that the drug will add to it. And even ketamine, and there's been some great pre-hospital studies that have shown that when you give ketamine in normal doses to shock patients, they can still become hypotensive despite what the label says that it's so cardiostable. So the dosage, I think, is even more important than the drug choice that you're ending up using. But by all means, think about that, but think about the physiology before you use the ketamine. Be careful as you're pushing it. It does cause apnea, which probably if you're pushing it for an RSI isn't so it's such a problem, but pushing it fast will more often than not induce apnea in the patient. So if you're just using it for some pain relief then be careful about how fast you're pushing it. And then the addition of fentanyl or not, some places start off with kind of a pre-dose of fentanyl and then give the ketamine. Um, I'm personally, I'm not too in favor of that, mainly because the benefit of giving the fentanyl is that you blunt the pain that happens when you put a laryngoscope in someone's mouth. And so the pain causes a sympathetic response, and that can cause an elevation in blood pressure and things like that, which can be a problem if you're intubating somebody, say, for a TBI or something, because it can raise their intracranial pressure. So I'm with ketamine because it's got intrinsic analgesic quality anyway, so I'm not always giving fentanyl before that. If I'm using another drug, say etomidate, then giving fentanyl beforehand in a TBI intubation can certainly be beneficial. And you have to give it a minute or two before you give the etomidate for it to work. And really, it helps in blunting that sympathetic response to laryngoscopy in a TBI patient when you really want to be really nuanced in keeping them hemodynamically stable for the intubation. So those are my thoughts on the drug choices for trauma intubation.
And Zaf, we're coming up on a hard out, so I do want to give you kind of the last word before we come back at this. Thank you so much for your time. You've been more than generous. There's certainly a lot that a lot of people need to hear and a lot that we've talked about. Something that we've started asking kind of at the end of every episode is a call for hope. Where it's easy to kind of look at the status of medicine in general and pre-hospital medicine kind of broadly and maybe be a little bit downtrodden about it. So I'm asking, looking forward, give us some hope for emergency medicine, EMS medicine. Where do you see these practices going, and how excited for the future are you?
I think it's actually, despite all the kind of challenges we've seen, especially after the pandemic, and I would say those challenges are related more to kind of the administrative structure that we work within, and that can be challenging to change. But the reality is, what we do matters. And I would say this really, just as an emphasis to all my pre-hospital colleagues, especially during EMS week, is that you are the front line. You are the person that shows up when someone needs help, and what you do matters. And in fact, I think this decade has been a real emphasis that we've reached a limit with what we can do by the time the patient gets to the hospital. And what we need to look at now is how we can improve things pre-hospital. So when you're looking at how we're modifying CPR, how we're bringing blood to the field, how we're thinking about even how we're taking patients to the hospital, for example, bypassing emergency departments and taking some patients to the operating room directly. That's what some agencies are doing. There's now much more focus on what's happening in the pre-hospital setting, which I don't think we've had for a long time. And so that gives us a chance to push ourselves to be even better than what we are already. And I think, overall we'll see what we do today really pay the dividends in the next 5-10 years.
And Zaf Qasim from Philadelphia, thank you so much for joining us, Dr. Qasim. We really appreciate it. Brilliant insight as per usual. We're excited to have you back on, and we'll keep talking about how to change and fix pre-hospital medicine. And guys, we'll be right back after the break. All right, Ed Bowder and Dan Schwester back on the Overrun. That was great.
Oh yeah, awesome.
Yeah, Zaf's a cool guy. He was really good of him to come onto the show, and
he's a rock star.
I mean, the conversations about trauma resuscitation, medical resuscitation. I feel like we're we talk about it a lot, but it's what we're here to do, right? And I think the conversations, like, we didn't get into pressers the way that I wanted to, but I mean, the heads up CPR stuff, the trauma, the whole blood things, I think that these are just kind of the most important things that we should be looking at right now.
Yeah, definitely. And again, the big thing I took from him was, the basics matter. All these gadgets are cool. All the toys are great. And look, I love my toys too. But it comes down to, for someone surviving a cardiac arrest, the right person has to have it. Okay.
Yeah.
And then somebody's got to get on their chest, and somebody's got to be doing compressions, and somebody's got to bring an AED to that patient. Okay. And then the advanced care can do their thing. And then the hospital can do their thing, and the cath lab and all the other tools in the armamentarium, right?
Yeah.
Then it works. If one part of that doesn't work, you're not going to have good outcomes. It's a team effort.
And I think we spend, and it's EMS week, right? So as we walk around, there's posters and banners talking about how we're all one team and one big family.
Free potato chips.
Free potato chips. Again, if your industry needs an appreciation week, you're not being appreciated. But and the reason that we did this for EMS week is there are systems that are working very well. There are high functioning systems that advertise themselves as high functioning systems who actually are high functioning systems, right?
Absolutely.
We talked about Hennepin during the show, where now you've got
there's a ton of them.
Yeah. Right. And, you'll hear your organization say, like, come on down and join a dynamic workplace where we're advancing medicine and doing all that stuff. And they're like, okay, show it to me.
What are you really doing?
Are you trying to do whole blood? Are you trying to do even though component therapy is outdated at this point, I would take someone who's looking to do component therapy. If you're doing RSI, are you using pressors? Are you using whole blood? Are you using all these things? And
how about just, are you doing research? Yeah. Are you seeing what works?
Right, exactly. And
is your medical director engaged? Does he come out and talk to you? Do you know who they are? Or is it just a signature on a piece of paper? These things matter, folks.
And that's the thing, these resuscitative practices, this isn't just stuff that goes onto a chart.
Right.
It's very easy to say, like, all right, well, we took the patient and we put 2 blankets under their head to elevate the head to facilitate intubation, and then we did heads up CPR. Like, no, that's not what it is. It's, and I think part of the thing is we talk about how we can advance and grow the profession, the industry, the practice. And a lot of it comes down to things have to be done in a perfect way in order for people to believe that they work. And we've talked previously on the show about throwing out the good in pursuit of the perfect. But this is a setting where if you're doing medical resuscitation, trauma resuscitation, you do not need to actually have, all these big sexy toys. You can do it without all this stuff, but maybe some of them make them better, maybe they don't. It's tough to know, but this is kind of where the data is trending.
Look, it's very simple. Do you do the basics? Do you do the fundamentals well? Okay. The mark of a championship football team is not their system. It's not the helmet. It's the fact that they can block and tackle and execute the basics better than the other team. And that's what they do consistently. Does your team do that? It doesn't matter what the toys are. We've had so many people on this show, Ed, and it all comes down to the same thing. It comes down to what the basics are. Do you do them well or do you not do them well? And you can always pursue perfection. That's a great way to go. You may not get there, but you're going to be a hell of a lot better than if you didn't do it at all.
Like the pursuit of perfection is not about the acquisition of perfection, right? You're always wanting to get to it. You're never going to be 100%. And, to belabor a sports metaphor, Bill Belichick is popular for saying, do your job, right? That's it. Just go out and do the thing, do the stuff that works. And again, if what you're doing isn't working, you have to sit and take the time to reevaluate why it's not working.
I'll tell you, I'll do you one better.
I'll do you one more.
I'll do you one more. Bruce Lee said, I don't worry about the guy who's practiced 10,000 kicks. I worry about the guy who's practiced one kick 10,000 times.
10,000 times. Yeah.
And there's a difference.
No, and I think that's great. And also, Bruce Lee has a famous quote that speaks to the flow state when you're doing, I think that can be applied to doing cardiac arrest, be like water.
I mean, it's a paraphrase, but give me a break.
Yeah, no, I completely get it. And I think that's true. I think, the more time you spend working on a procedure, the better you're going to be. And by proxy, the better patients' outcomes are going to be. But happy EMS week, everybody. Thank you for joining us. We want to know what you guys think.
Enjoy the hot dogs and hamburgers.
Enjoy your barbecues and your lunchbox, coffee cups, water thermoses, umbrellas. I'm going to guess. And let us know what you guys think.
Send us your EMS gifts on social media. We'll republish them. We want to judge.
On TikTok at the Overrun, Instagram and Facebook at Overrun Productions. Let us know what your EMS week gifts are. We're excited to see them. Subscribe down below and the button that I never know where it is. We will talk to you all next time. And for the Overrun, I'm Ed Bowder.
And I'm Dan Schwester.
Happy EMS week. We'll talk next time.